Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Stevens-Johnson Syndrome. Stevens-Johnson Syndrome is a painful blistering skin condition which is due to an immunological response to various stimuli. The causes are wide-ranging but can include infections and drugs. However, 25 to 50% of cases are idiopathic. Stevens-Johnson Syndrome, or SJS, is more common in children and younger adults but can develop at any age. There are certain high-risk populations to be aware of, particularly in the context of MRCP examinations, and these include symptoms after taking specific medications, a weakened immune system, people with HIV and AIDS, people undergoing chemotherapy, and family members who have had SJS. SJS is characterized by widespread bullous skin lesions and classically presents as an unwell adult with fever. The condition is characterized by painful mucosal inflammation and ulceration, including orogenital, mucosal, and respiratory epithelium. There is characteristic hemorrhagic crusting of the lips also. A thorough history and clinical examination, including orogenital examination, is crucial in the diagnosis of SJS. It is important to exclude septicemia, which is a classic mimic of the condition, and to do this should include blood tests including full blood count, renal function, and liver function tests. A chest X-ray should also be performed. Along the same vein, mycoplasma serology, HIV and HSV serology should also be performed. A skin biopsy may also be useful in clinching the diagnosis. The treatment of SJS is largely supportive with good nursing care required. These patients may require intensive care or the burns unit, especially if there is evidence of septicemia. It is important to look for and suspend potential triggers, including drugs. The patient should be nursed on air fluidized bed, along with being given analgesia. When handling the patient, it's important to use an aseptic technique with minimal skin handling. Fluid replacement and nutritional supplementation is often required, and during monitoring of the patient, an urgent ophthalmology referral should be made if there is any suspicion of ocular involvement. There are several potential complications of SJS which people should be aware of. This can include dehydration, including leading to an AKI, electrolyte loss, protein loss, hypoalbuminemia, secondary to the protein loss, septicemia, an inability to eat or drink, scarring, and blindness when there is ocular involvement. So as you can see, SJS is a classic example of a condition that requires input from the multidisciplinary team and early and prompt intervention to try and achieve better outcomes. So let's try a question. Which of the following is a common histopathological finding in SJS? So our options are acanthosis and hyperkeratosis of the epidermis, hypocellular dermis with abundant collagen production, dense infiltration of eosinophils throughout the dermal layers, separation of epidermis at the dermo-epidermal junction, and unilocular bullae formation in the subepidermal space. So the correct answer here is option D, which is separation of the epidermis at the dermo-epidermal junction. It's really important to try and remember histopathological features, especially in dermatology for the Part 1 exams in particular, as these may well come up in the exam. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.